Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to welcome all of you, our attendees, to attend the 6th Saudi Ophthalmology Society webinar, which is focused in Retina Fellows Round with experts. It is a session that concerns with the discussion of retina cases that between medical and surgicals. And I would like to take this opportunity to thank my colleagues, our fellows, and as well our panelists. I would like to thank Pearse Dr. Abdullah Al-Bihlal, who is really organizing most of this webinar, and our speaker, Dr. Dua Malibari, second year fellow in King Khalid Eye Specialist Hospitals, and Dr. Faisal Saeed Al-Gahtani, first year fellow, King Khalid Eye Specialist Hospitals, Dr. Hamad Al-Subayyi, first year fellow, King Khalid Eye Specialist Hospitals, Dr. Mustafa Maglia, second year fellow, King Khalid Eye Specialist Hospital, and Dr. Tariq Al-Zahim, first year fellow, King Khalid Eye Specialist Hospital. I would like to extend my thanks to our panelists for accepting our invitation to be with us and to share us their experience in the presenting cases. Professor Salih Al-Amru is a professor of ophthalmology, consultant retinal and uveitis at the Eye Consultants, King Khalid Eye Specialist Hospital, Riyadh, Saudi Arabia. As well, I would like to thank Professor Marwan Abu Ammo. He is a professor of ophthalmology in King Saud University, King Abdulaziz University in Riyadh, as well to thanks Dr. Muhammad Al-Hazzazi, an assistant professor, retinal consultant at King Saud bin Abdulaziz University for Health Science in Riyadh, as well to extend my thanks to my colleagues, Dr. Sulaiman Al-Sulaiman, Senior Consultant Retinal and Uveitis Division, Associated Director of Fellowship and Residency at King Khalid Eye Specialist Hospital. I would like to extend my thanks with our collaborator, Saudi Retina Group, as well King Khalid Eye Specialist Hospital, to be with us in this Retina webinar. I would like to call the first presenter, Dr. Abdullah Al-Bihlal, to present his case. Please, Dr. Abdullah, can you share your PowerPoint presentation?
Sure, Dr. Assalamu alaikum wa rahmatullah. Good evening, everybody. I'm really happy and grateful to be among you today. Thanks, Dr. Hassan, for the introduction. Also, special thanks are extended to you for moderating and organizing this session on behalf of my colleagues. And I'd like to also thank the respected panel for being with us today. I'm really sure that myself and my colleagues and also the audience will enjoy their valuable remarks. So starting with the first case, actually it's a retinal detachment with macular hole. Retinal detachment cases can be simple and can be complicated. And when you have macular hole associated with your retinal detachment case, it's not usually a simple case, and you have to have preoperative and intraoperative considerations to be able to approach this case. So starting with this case, I'd like to thank Dr. Hassan for sharing this case with us today. This is a 49-year-old male who presented to King Khalid Eye Specialist Hospital emergency room with progressive superior visual field defect in the left eye for 10 days. He is medically free apart from hypertension that's controlled with antihypertensive medication. In terms of ocular history, he has myopia with axial length of 26.8 millimeter, 26.5 millimeter on the left eye. Unfortunately, there is no refraction recorded in the file. Otherwise, the ocular history is unremarkable. There is no history of surgery or trauma, and there is no family history of retinal detachment. At the visual acuity was counting finger on the involved eye, which is the left eye. The anterior segment exam was otherwise normal and unremarkable. The lens was clear. The fundus examination of the right eye, as you can see in the top photo, is normal with some myopic appearance. The left eye, as you can see here, is involved with almost subtotal retinal detachment. The detachment is involving the macula. There is macular hole, as you can see here. We can see here also a vice ring, possibly indicating clinical BVD. There is early BVR proliferation. You can see a possible proliferation and formation of early star fold in this area. There is also a localized choroidal detachment temporally and infratemporally. The causative breaks are actually highlighted to be in this area, superatemporal, and also there is a couple of flap tears inferiorly. So this is an OCT confirming the presence of full thickness macular hole. So now the question is directed to the respected panel. What's your preferred surgical approach for this case? Are you going to do vitrectomy or combined vitrectomy with sclera buccal? What is your ILM peel technique, and is there any consideration in that regard? Are you going to do 360 laser or not? And what's your tambonide of choice? And do you have any additional consideration to add to this case? Dr. Hassan,
okay. I would like, in such questions like that, I would like the more senior of our, panelist, Professor Al-Amro. Could you help us to just highlight answers about these questions, please?
Bismillah ar-Rahman ar-Rahim. Just to reiterate, the two couples of tears are inferior, huh?
Yeah.
Because I was right. Disconnected.
Yeah,
there is a temporal one and 2 or 3 a couple of breaks inferior.
Right, that large break inferior around 2 disc diameters, and there is as well in the nasal side there is a small horseshoe tears.
On the temporal side.
Yeah, in the nasal, if and though.
Yes, actually, it's in the temporal side here.
Temporal.
Yeah.
Now, well, this is I will go for definitely for Pearse plan vitrectomy, and as there is no much of BVR, I will probably go without encircling, and I will do complete vitrectomy, of course, inducing all the posterior hyaloid detachment if it's not complete. And then you see the thing that also we used to do even before the era of routine vitrectomy, that the macular holes, which is associated with the rheumatogenic detachment, and drain all the fluid, they will even without these days will as long as there is no BVR, there are two choices.
Prof. Saleh, your sound is really actually not clear for us. Sometime is going.
Just 1 second, please. Just 1 second. Let me see what's going on.
No, it's okay now.
Now?
Yeah.
Okay. Now, so now there are 2 ways to go, but I will let you know of my preference later on. Now, now mine is BPV, and then either to go with no ILM peeling and just direct yourself to drain with heavy liquids, and then through the peripheral breaks, then go and do endolaser for the peripheral breaks. I usually don't go and do 360 degrees laser, because as long as there is complete peripheral vitreous detachment and you do a good peripheral shave, you don't need to zap all the retina 360 degrees. But there are also problems with this. And then go and, since there is inferior breaks, I will go for silicone oil. Also, what I use now is the heavy silicone oil, in fact. And this is one way of, and in fact, there are studies shown very well closure of the break, even with without ILM peeling, without any problems. But now with high myopes, probably I will tackle and go do the ILM peeling. Now, with a detached retina, the best, in fact, technique is to go and do it under heavy liquids bubble. And I think the marble sort of rotation with a small one is a very good technique, making sure that there is no fish eggs, so that no bubbles of heavy liquids will go under the retina. So
okay, your sound. Your sound is good.
Then the preferred technique, I will go and pinch and peel. And also, once you commit yourself to ILM peeling, I will extend it also into the anterior, so that there will be no scaffold for future BVR.
That's great. Any additional from our panelists in 1 minute, please? Dr. Hazzazi, you would like to add anything to what?
I think this patient is a phakic, right? Isn't it, Abdullah?
Yeah, yes, clear lens, yeah.
Yes. So if it is my call, I will go for buccal, because if I'm not going to have as clear as possible shaving to the periphery, and you can see that the pathology is combined. We have macro hole and we have peripheral multiple breaks. So probably you may miss one or two. If the buccal is there, will definitely support all the peripheral or the base of the vitreous. The other thing that even I can go with gas without even silicone oil if I'm going to use a buccal.
Okay, Dr. Abdullah, could you continue? If you have any questions, you can feel free to ask.
I have one.
Yeah, Hassan, can I add one thing, Hassan? I think the encircling band is to support the vitreous space, but it will not close the peripheral breaks if you don't make sure that the buccal is on the breaks. And probably putting a band, this will support the vitreous space, and probably this will
Dr. Saleh, you have to look for your mic. It's not really. Sorry, Dr. Saleh. I will give the chance to Dr. Suleiman. Could you comment, please, Dr. Suleiman? Dr. Saleh, your voice is not usually clear for us.
There is a problem with the connection of Dr. Saleh.
BVR happens, will be less.
Okay, great. Dr. Suleiman?
So I have one comment regarding the macular hole in this case. So this is a secondary macular hole. This is not a primary macular hole retinal detachment. So there are peripheral breaks that are causative of this retinal detachment, and this macular hole is secondary. I would not push for any ILM procedures in the first go, as it may close because of your usual RD repair. If I have to do something, then
yes.
If it remains open, I'll probably do a lab in the future.
I will go with my.
I cannot hear.
Yeah, could you have Dr. Abdullah go, please? Because the time is limited, guys, because we have exceeding the 10 minutes. Dr. Abdullah?
Okay, so a decision by Dr. Hassan Al-Dibi was to go for combined sclera buccal procedure plus Pearse vitrectomy, and here is the surgical video. So 360 conjunctival periotomy was performed for exposure of the recti and the surgical space. Hooking and isolation of the recti muscles was done with 2O silk. The encircling element was passed the 360 underneath the recti muscles and was fixed with nylon suture to the globe. 23 gauge Pearse vitrectomy trocars were inserted, and the infusion cannula was inserted and verified to be in the vitreous cavity. So this is just an inspection of the fundus and how it appears. Actually, this confirms our previous clinical photo. You can also see here that we have macular hole and the detachment of the macula. So core vitrectomy was performed, vitrectomy around the trochers, and some peripheral vitrectomy was done, especially to amputate the flaps of the flap tears. Membrane PIC was used to attempt to elevate any epiretinal BVR proliferation at the area of the BVR early star fold here. But actually this failed to show any actual BVR membrane. Diluted triamcinolone solution was injected, and this confirmed the presence of BVD at least in the posterior wall. Membrane dual solution was injected to highlight the ILM and highlight any membranes covering the posterior pole. Choice of stabilizing the retina with perfluorocarbon liquid was done, and this can help counteract the forces and allow easier ILM peeling. So an edge or a flap was created using Tano scraper, and then a small 360 ILM peel was performed with a flap that was stuffed into the macular hole. Then the perfluorocarbon was advanced, and then additional vitrectomy was done with sclera depression. All the peripheral breaks were identified, and then treatment with the laser retinopexy was done to the responsible breaks, as well as 360 laser retinopexy was done. Then the endodrainage was performed with the fluid air exchange, and then the choice of tamponade was actually silicone oil 5000 centistoke up to the level of the posterior lens capsule, leaving a meniscus, small meniscus of air to guarantee that there is no overfill. And the sclerotomies were closed, and the conjunctival periotomy was closed, and the eye at the end of the procedure was normotensive and stable. So this is the end of the surgical video. We can see now the image of the post-op photo 3 months later after the surgery. And this was actually recently. As you can see, the media is not very clear because of some posterior subcapsular cataract. However, the retina is completely flat. You can see temporally that we have the buccal indentation clearly present. And it's also present 360, the buccal indentation with 360 laser scars. Visual acuity improved from counting finger to 2200, and this is the appearance of the OCT, the horizontal scan of OCT. You can see that we have a closed macular hole with some residual glial tissue here and some small defect of nerve fiber layer. So key points to add about this case is that surgical approach for combined macular hole with retinal detachment is more challenging than surgery for isolated macular hole, or even surgery for isolated retinal detachment. The primary challenge is actually the ILM peel over detached retina, and you can counteract the forces with using perfluorocarbon liquid, which can stabilize the retina for you to have safer type of ILM peel. However, in this, if you use perfluorocarbon, you need to provide good staining with brilliant blue or membrane dual, which might help you, because you will not be able to gain free-floating ILM flap because the perfluorocarbon is pushing the ILM flap, and you'll not be able to lift it up. You need to take care not to drain the subretinal fluid through the macular hole. This can cause damage to the photoreceptors and also can enlarge the macular hole. If there is, as Dr. Sleiman mentioned, if there is a primary type of macular hole and you have a patient with high myopia with staphyloma and there is no peripheral breaks present in the case, you can just observe the subretinal fluid, which might take months or even years to resolve.
So, Abdullah.
Thank you, Dr. Abdullah. I would like now just give 2 minutes, please, for discussions because we have still of cases. When I looking for this case from inside the OR, there is actually a posterior vitreous detachment, but it cannot be traced to the periphery of the ora serrata, and the retina at the periphery is very thin. And further manipulation at this area, it might lead to further breaks. So and already the patient developed some sort of BVR, so that might be giving prediction this patient might in the future get some of this. So I selected the buckles, and as you see, there is the break that inferior at 6 o'clock was large. So I actually I put the buckle and put it little bit you know, posterior, so that it can a bit support the tear. My way that usually I like the, you know, to do 360 degree, although yani it's not actually with the good vitrectomy that you can go for that. The macular hair surgery here, as you see, the macular hole is not that small, so that I leave it like that, it might be lead to, you know, recurrency. And so I did the ILM and I put silicone oil to make sure that the case is getting full procedure, and especially this case came at the time of the COVID, you know, pandemic. Considering all your comments, which is really practical, but some debate in these situations usually there. Dr. Suleiman?
So one comment regarding ILM flaps and myopic RD. So if you have high myopia with macular hole related retina detachment, studies have shown that if you do ILM flap technique, the success is higher than doing ILMP. However, this case is not a primary macular hole retina detachment. This is a secondary macular hole, and the detachment is due to peripheral breaks. So yes, you can do the ILM flap, ILM peel. I don't think it is necessary at this stage. It's good that you did this in one step, and I think this is a very beautiful outcome. But I would not push myself to try to put the ILM flap in the first surgery, or build the ILM and lose my ILM flap chance in the future.
That's great. Thank you, Dr. Suleiman. Because the time is limited, could you go for the second speaker? Dr. Abdullah, could you stop sharing? Okay, Dr. Dua. Could you unmute yourself, Dr. Dua?
اي معك دكتور.
Okay, please start. Dr. Dua is second year fellow.
Good evening, everyone. This is Dua Milibari, first year medical retina and uveitis fellow. In the coming 10 minutes, I will try to summarize a challenging as well as interesting case and thanks to Dr. Levy for providing me this case. This is a 41 years old medically free lady. She presented to the ER with a history of gradual decreased vision in both eyes since 5 years, with significant deterioration of her vision in the past month. She was seen in different hospitals, underwent 2 labs as well as MRI, and all of them were negative, and she was referred to us as Bahjat disease. She already started on topical as well as systemic steroid. Past ocular history was negative for trauma and surgery. Systemic review and constitutional symptoms were negative. Upon examination, the vision in the right eye was 2200 and in the left eye 2040. She was having a mildly injected conj with motor and fat KPs, 2+ anterior chamber reaction. Dilated fundus examination revealed dense vitritis with no view in the right eye and grossly flat retina in the left eye. This is her slit lamp photo. As you could see, there's a motor and fat KPs with a dendritiform appearance. B-scan showed a dense vitreal opacity with mild subvitreous opacity and PVD, as well as no any detectable masses or retinal detachment. So the impression was a chronic panuveitis for investigation. So we ran a full uveitis workup. All were negative apart from elevated C-reactive protein. We repeat her MRI. And her MR showing a multiple abnormal high patches, mainly involving the bilateral frontal hemisphere. And the conclusion was the possibility of vasculitis should be put in the consideration. So we start here in topical as well as systemic steroid and immunosuppressive medication in form of Celicept 1 gram BID. And 5 months later, the patient showed equivocal response. So our impression was uveitic masquerade syndrome with a high possibility of primary vitreoretinal lymphoma versus CNS lymphoma. And the next step was to repeat her uveitis workup, including her MRI. The third uveitis workup came negative, and her third MRI showing again multiple patches in mainly prominent in the frontal lobes, and became more prominent compared to the last MRI. No any evidence of demyelinating lesion. 1 year later, the patient came with sudden drop of vision. The vision in the right eye were 2400, and in the left eye hand motion. Slit lamp examination, she was having a quiet conge, occasional cells reaction in the right eye, and 1+ reaction in the left eye with endothelial dusting. She was having an early cataractus changes, and her fundus examination revealed a dense vitritis with a subretinal infiltrates, as well as disc elevation and pre-retinal hemorrhage. B scan showed a dense vitreal opacity with mild subvitreous opacity. So we repeat her MRI. This is her fourth MRI. Again, there was multiple hyperreflective patches, mainly on the frontal hemisphere. No any lymphomatous masses was detected. So the question to our panelists, now we have a relatively young lady. She is only 41 years old, medically and surgically free, underwent to full uveitis workup, 3 workup, all of them were negative, and 4 MRI, and all of them are not supportive. So I would like to ask, what's your approach? What is the next step?
Professor Marwan, could you help us to answer these questions?
So as I understand, the patient has passed through many doctors before reaching the eye hospital, and then after many suggestions and possible diagnoses, you thought of primary intraocular lymphoma. This is usually poses a diagnostic dilemma, and it's not a straightforward diagnosis, and not a common thing to see. Given the MRI findings that supports the fact that this patient has an intraocular lymphoma, and the severity of the picture, it is not a bad idea to do a vitreous biopsy, and to check for. Of course, now some have thought of doing OCT or autofluorescence, but in such cases with dense vitritis, there's possibly no view. So a diagnostic vitrectomy, checking for interleukin 6, interleukin 10, and in addition to cytology, and sending for culture for possible other diagnosis, other possible.
Yeah, thank you, Prof. Marwan. Actually, it is really the next step in this case, as this is equivocal, as we have an equivocal response. So the second steps, yes, please. Dr. Marwan, your sound is not actually getting any for us. So we'll continue with the case.
Examination, with possibly you will biopsy. It's important that you have.
Yeah, your voice is really not clear for us, Dr. Marwan. Could we continue with the case?
Okay. So as Dr. Marwan, as Prof. Marwan suggested, we go for diagnostic vitrectomy in the left eye, and this is the surgical video. So under dry vitrectomy, we took a 1 to 2 ml of undiluted vitreous sample, and then the air was replaced with a air fluid exchange, and core vitrectomy was performed. And as you could see, there is a multiple large area of creamy color subretinal infiltrates. With also here, if you could notice that there's macular scarring, and it's important to know that if you are planning to go for a diagnostic vitrectomy and the patient was already on steroid, due to presumed uveitis, it's important to stop the steroid at least 2 weeks before we go to diagnostic vitrectomy, because the lymphomatous cells are extremely fragile and prone to necrosis, and to avoid a false negative result. And here they are closing the sclerotomy, and subconj decadron is giving. This is her post-op picture. As you can see that the vitreous debris is almost cleared, and the media and the view was much better. But there is a large area of creamy color subretinal infiltration with pre-retinal hemorrhages. Her vision is improved. Her histopathology report showed a monomorphic small lymphocytic infiltration, and lymphoma cannot be ruled out. So the next step was the plan was to go either to a repeat vitrectomy plus minus retinochoroidal biopsy. But unfortunately, our patient deteriorated. She developed multiple seizure attacks. She was comatose, admitted in the ICU, and in the ICU, they did an MRI number 5, and unfortunately, at this time, she was showing a large lesion, a discrete lesion that causing brain edema and midline shifting, and unfortunately, she passed away. So just I will clarify a few points regarding the masquerade syndrome. It was first described by Theodore to describe the case of conjunctival carcinoma that presented clinically as a chronic conjunctivitis on 1967. There is a 2 large retrospective study reported the frequency of masquerade syndrome within 2 uveitis centers. The first one was by Rethova. He found that uveitis masquerade syndrome diagnosed in almost 5% of the patient, 40 out of 822, and 48% of those uveitic masquerade syndrome were found to have an intraocular lymphoma. The second report by Grange, he reported that uveitic masquerade syndrome, around a prevalence of 2.5%, were diagnosed with neoplastic masquerade syndrome. So primary vitreoretinal lymphoma, it's a rare ocular malignancy that primarily arises from the vitreous or the retina, and it's considered as subpart of primary CNS lymphoma. It's considered the most frequent type of intraocular lymphoma, and it represents fewer than 1% of all intraocular tumor. The estimated annual incidence is around 0.4 per 100,000 person. It has been estimated that around 80% of primary vitreoretinal lymphoma will finally develop primary CNS lymphoma, and 20% of the primary CNS lymphoma cases will present with the primary vitreoretinal lymphoma. 70% of patients of intraocular lymphoma, they presented with anterior and posterior uveitis, and around 60% up to 83% have bilateral involvement. 95% of primary vitreoretinal lymphoma are histologically classified as diffuse large B-cell lymphoma. Primary CNS lymphoma should be suspected in any old age patient or immunocompromised patient with posterior uveitis and has negative workup. Despite the rare occurrence, the primary vitreoretinal lymphoma remain diagnostic and therapeutic challenge, and the diagnosis can be confirmed by a variety of ways, including multimodal imaging, neuroimaging, cytology, immunohistochemistry, and molecular pathology, cytokines analysis, and gene rearrangement by PCR. This is a table that summarizes the imaging feature of a primary intraocular lymphoma, but for the sake of the time, I will skip it. And 16% and up to 34% of the patients have have CNS involvement upon presentation, and around 42% to 92% will develop CNS lymphoma within 8 to 29 months. So neuroimaging is indicated for all patients with a primary vitreoretinal lymphoma due to high incidence of CNS involvement. Patient also can have a CSS cytology, because elliptomeningeal involvement can present in the absence of detectable parenchymal lesion. Vitreous biopsy remains the gold standard for diagnosis of primary vitreoretinal lymphoma. And as we all know that very often primary vitreoretinal lymphoma present as masquerade syndrome, making the diagnosis extremely challenging and complicated. Differential diagnoses include wide spectrum of infectious and non-infectious disorder. Therapeutic approach of primary vitreoretinal lymphoma involve aggressive systemic chemotherapy as well as intravitreal chemotherapy and radiation therapy. And this is the new guideline by the European guideline of primary vitreoretinal lymphoma. Despite the aggressive treatment, primary vitreoretinal lymphoma has a very poor prognosis, and the mortality rate range from 9% and up to 81%. And the 5-year overall survival rate is around less than 25%. So, sorry for the long talk.
Thank you, Dr. Duam. This was great presentations. I think there is a lot of things that could be يعني getting from this case. Actually, it was tough case, and I would like to say Allah يرحمها ويغفر لها إن شاء الله. But it was really يعني difficulties from this patient is not accepting to go for diagnostic, vitrectomy from the beginning. But then we actually, with the long discussions, she agreed to go for that. Although the vitreous samples were sent for multiple purpose, as Professor Abu Ammu said, for interleukin 6 and 10, as well for cytofluorometry, as well to go for histopathology, and all this is coming difficulty to rule out, even though the lymphoma. If you're looking for the presentation, actually it is not the same presentation that we looking for, but this is the life of masquerading. This is coming with really extensive infiltrate. It's almost like the case of acute retinal necrosis. So it was difficult, and suddenly everything is coming together. After even 4 MRIs, there is no signs of CNS lymphoma, and by the end, the patient get in the other way and discover to have the mass. We have only because we are really exceeding our time. If you don't mind, we can move to the second case. If there is something by the end, we can discuss it regarding to this intraocular lymphoma. The vitrectomy for intraocular tumors, it's actually it's better to go through the dry vitrectomy by starting filling the eye with air and getting your samples, and then you go to the regular vitrectomy after you putting air fluid air exchange. And you take as much as if you can. This could help to increase the the sensitivity of the samples to be detected for the lymphoma. Who is the next with us, please? Dr. Faisal? Dr. Faisal?
Yes.
Could you share your screen, please?
Assalamu alaikum. Thank you, Dr. Hassan, for inviting me in this webinar. I'm Dr. Pearse Said Al-Qahtani, first year fellow at the Veterinary Retinal Department at KKISH. My case is about the management of retained subretinal perfluorocarbon liquid. So this is 15 years old male, medically free, presented with complaining of vision loss in the left eye and superior visual field defect for more than 2 years after a blunt trauma. So the blunt trauma was 2 years back, and he presented now after 2 years. Actually, he did not seek for ophthalmic evaluation since the trauma. This is the ophthalmic exam. If you can see the left eye, the vision is 4 out of 200, and the IOP is within normal. Other anterior segment exam is fine. So this is the fundus photo of the left eye, of the involved eye. We can see inferior retinal detachment with with signs of chronicity, subretinal bands and demarcation lines. And this is the OCT, which shows the retina is detached at the macula. So the impression was inferior rhegmatogenous retinal detachment, the macula off with BVR and demarcation line. So the plan initially was started with scleral buckle, but unfortunately scleral buckle was failed. Then vitrectomy was the next option. So a partial vitrectomy with PFCL, fluid air exchange, endolaser, and 1300 silicone oil tamponade was the surgery. So after the vitrectomy with 2 weeks, the vision is 2300 in the left eye. And this is the fundus photo of the left eye. We can see inferior to the fovea, there are multiple perfluorocarbon bubbles with PFCL bubble at the fovea. It's clear with OCT. This is inferior cut of OCT from the fovea. We can see 2 PFCL bubbles, and at the fovea, there is 1 PFCL bubble. So the impression was retained subretinal PFCL. So the question to the respected panel: so how would you manage this retained PFCL in this case? Would you observe, or you will go for surgical intervention? So in the case of surgical intervention, will you proceed in which surgical procedure?
Professor Saleh, could you help us?
Now, usually when you have a retained heavy liquids under the retina, if they are tiny or if it is tiny away from the macula, I usually leave. But now with this one, multiple and subfoveal, I will definitely go and remove it. And by use of smaller gauge needle, 38, 40, 41, and the one you can go and just do your penetration and then vacuum from the heavy liquids bubble. And this way, we know that the heavy liquids is toxic once it is in the subretinal space. So I will definitely go and remove them.
Okay, Dr. Muhammad.
Yes, I think that I'm just echoing Professor Saleh for the same thing. If it is involving the macula, and this is a young patient expecting long life to live, so the bottom line, if it is involved in the fovea, it has to be displaced away. So either aspirated by using a fine or a small needle 41 gauge, or the other modality or another technique to induce a detachment, again using 41 or 39 needle, injecting the BSS in the subretinal space. Then as prescribed by Crickback earlier in 2008 maybe, the patient will be placed in upright position after the air fluid exchange is performed. So the aim for this technique to move the perfluorocarbon away from the fovea. Yes, I heard about other techniques that doing internal limiting membrane and using the backflash cannula just on the retina directly, and this technique, provoking that it may, for this kind of small bubble, will like diffuse through the retina outside. I haven't used this technique. However, the previously described technique by Crickback was the most useful one.
Thank you, Dr. Muhammad. We'll proceed for the video, and I wish that, or I would like to call even that Dr. Aguili, if he could share us, as he is the primary surgeon of this case. So, Dr. Shamrani, if you could allow for Dr. Adil to make comments about when he's finishing this case. Dr. Faisal, could you proceed?
Yes. So the surgery was siliconoid removal, SUH out, and subretinal pieces with using of C3F8 gas in the left eye. The primary surgeon is Dr. Adil Aguili. Thank you for him. He providing us this case. So we'll start with the video. So we can see now and visualize the perfluorocarbon bubbles at the fovea. So, so the surgeon now will introduce a 39 gauge needle to create a pocket of subretinal pieces or bleb by 39 gauge needle.
Forward.
So he created now the pocket of fluid gradually. So, but the issue is the fluid is limited and localized temporal, did not extend to the fovea. So he will try to inject more of the subretinal space, trying to create contact to the fovea. I'll try to make it. So it is. So it's localized and limited. So he's trying now other location. and the same thing. It's localized. So what he's gonna do? So he will do something is, I think it's smart idea. He will shift to air fluid exchange, seeking the help of the air to squeeze and force and pushing this fluid to the fovea.
Thank you, Faisal. Do you hear me?
Yeah.
Yes, we are hearing you. Good.
Yeah.
Okay, I think Faisal has nicely described the procedure. But basically, the idea is that we were always going back to trying to inject the subretinal BSS, and it always shifted to that temporal blip outside the foveal area. And this was wherever we changed the location of the injection, it remained, it still went to the same location. So the idea is that once we start doing an air fluid exchange and gradually start to suck the fluid from the edge of the blip, it starts to detach a little bit more, and gradually we reach the fovea, and then basically the perfluorocarbon bubble would be now connected to the subretinal blip, or the blip itself. And this will help in basically allowing it to move away from the center of the fovea under the retina. And basically this was what happened in this case. So the idea is that sometimes you intend to inject the subretinal, use the subretinal needle to inject, and then you end up creating a blip that's outside the fovea, and you sometimes get stuck with it. And this is the challenge in this situation.
Dr. Faisal?
This is my comment.
Yeah, thank you very much, Dr. Adil. Be with us, please, for a while.
Absolutely, sure.
So thank you, Dr. Adil, for your comments. So questions to the respected panel. We know that macrohole is one of the complications of the injecting of subretinal bases. So how do you avoid when you inject by 39 or 41 gauge? How do you avoid the macrohole? So I mean, in terms of speed, velocity, the amount, the location. This is
Dr. Suleiman, could you help us?
So a very elegant technique, Adil. So in order to avoid macular hole, you have to watch what you are doing. Slow rate of injection, and watch for stretching. If you see the fluid is approaching, or the fluid is going to the fovea, then you can stop and select another location if you need more fluid in the subretinal space. For this case, I would have done it a bit different in terms of where the location of injection would be. I would have injected it inferiorly rather than temporal. And yes, if it doesn't go to the fovea, you can do the fluid air exchange in order to push it to the fovea.
Okay,
good.
Okay.
Thank you.
Thank you.
Yeah.
Next question, if you allow me, Dr. Hassan, what type of intraocular tamponade? So would you use like CF6 or SF6 or C38 or even air? So is there any favorable tamponade for those cases?
Maybe Dr. Marwan, could you help? Are you hearing me? Dr. Suleiman, could you continue, please? Dr. Marwan, go ahead, please.
Yes, I couldn't hear the question.
Yeah, what type of intraocular tamponade that could help in such case?
After removing the silicone, the heavy liquid bubble?
Yes, in such case like that, maybe Dr. Adil is already.
You can gas will suffice. You don't need the silicone oil.
Okay,
if you remove the.
You will go with gas, right?
Yes.
Okay.
Can I comment?
Go ahead.
Now the scenario is, if you use silicone oil in these eyes, then you will discover the presence of subfoveal perfluoron early on. In the first few days after surgery, you will discover that there is subfoveal perfluoron. Then The question is, when should you remove it? There is no agreement, but the earlier the better. I'm sure that everybody has his own feeling regarding when it should be removed, but I personally prefer that I wait for the chorioretinal adhesions to form from the laser and cases of retinal detachment repair, and then go ahead in 2 weeks and remove it. If I feel that the chorioretinal adhesion is enough and we achieved good seal of retinal breaks, then air or gas can be sufficient. If it is something that I need a longer acting gas, then I will consider what Adil did, which is C388 in this case.
Okay. Because sake of time, I would like to ask Dr. Aqili if he would like. Go ahead, Dr. Faisal.
Okay, so thank you. So the post-op exam 3 months later, in the left eye, the vision improved to 20/200, and the retina became flat. So this is the OCT picture 3 months after. Okay, so I have just some slides to discuss about the displacement of subfoveal.
Make it brief, please, because the time is...
Okay, displacement with removal. This method involves the induction of macular retinal detachment through juxtafoveal or paramacular retinotomy and removal of Pearse cell bubble by gently flushing with or injecting saline solution. So without removal is the thing that Dr. Adil Aqili he did. So this method involved creation of retinal detachment at the posterior pole and the inferior periphery through a retinal puncture near to the infratemporal vessels with air fluid exchange and tamponade and upright positioning with the patient. This is a quick review to the last, the most common procedures of subretinal Pearse cell. We can notice the direct aspiration by small gauge is the most common, but as well as the displacement without removal have been reported in the literature. So a conclusion, the ultimate visual acuity may be affected by many factors such as the location, the size and duration of the subfoveal Pearse cell, and as well as the iatrogenic injury during its removal. So due to the lack of randomized and controlled trials, as well as the complexity of the clinical situation, to date, no secure technique can be recommended for removal of subfoveal Pearse cell in different cases. And thank you for the panel. Thank you for you, Dr. Hassan, and for Dr. Adil Aqili.
Thank you, Dr. Faisal. Great presentations. Dr. Adil would like to give some, comments.
I really thank Faisal for the presentation. I think he covered everything. I just wanted to add a small advantage of having an intraoperative OCT, which was something that Prof. McLaren described when using subretinal injection in his choroideremia trials, was when you basically have the intraocular OCT, you can always observe the foveal depression once you start injecting. And what he described is once you start to see that the foveal depression has basically become straight, you have the whole blip forming, but I mean the depression at the fovea exactly in the retina, when it becomes straight, this is the time that you actually have to stop, because that's when you run into trouble and causing sometimes a hole in those situations.
Yeah. Thank you, Dr. Adil, for really, and congratulations for this really great case. And I think so we have enough discussion about it. I will move now to the next speaker, Dr. Hamad Al-Subi'i, and he's going to talk about Hamad, show us what you would like to see.
Assalamu alaikum.
Assalamu rahmatullahi wa barakatuh.
I'm Hamad Al-Subi'i, first year surgical retina fellow. It's my pleasure to present this webinar. My case is about RRD in eye with thin sclera. I describe it as walking on thin ice. A special thanks to my mentor, Dr. Abdullah, who allowed me to present this case. Our case is 35 years old male. He's a one-eyed patient. The seeing eye is right eye. He's known in case of myopia, juvenile glaucoma, and scleromalacia. He presented with decrease in vision in his seeing eye for 2 weeks. On exam, his visual acuity is 2200, was 2060 as a baseline on the right eye, and 2400 on the left eye. IOP was 8 on the right eye and 15 on the left eye on anti-glaucoma medication. On second examination, he's having thin sclera with the uveal show in both eyes. on the anterior segment exam, he's having clear cornea with deep ACOU and with clear lens on the right eye and IOL place on the left eye. In the fundus examination, he's having RRD macula off with 0.9 cupping on the right eye, and he's having flat retina with total cupping on the left eye. This is his external photo of the right eye, the seeing eye, showing a very thin sclera with the UVL show. And this is his fundus photo of the right eye, showing a superior temporal RD involved with the macula. And you can notice also the advanced cupping around 0.9 cupping. My question to our panelists, and what's the best surgical approach in this patient? Keep in mind he's a one-eyed patient with advanced glaucoma and considering his very thin sclera.
Prof. Saleh?
Now you're managing, this is what I would suggest. I didn't see I think there was a problem with internet pictures, but now what I would suggest is I will now, with the use of the strips, silicone strips, you can also go inside, do a vitrectomy, and with a routine management of the detachment. What the caution I would take is go smaller gauge vitrectomy, 25, and it doesn't seem that there are membranes, too much membranes to dissect. 25 or even 27, and then with these silicone strips over the thin sclera, trauma to the sclera will be quite minimal, and even you can have sort of self-sealing even with this thin sclera. And what I also propose, even to seal this, you can have fibrin glue at the end. But I myself, also I could see that the thin sclera mainly sort of in the anterior part. If one plan, I can't not see all the details, but also doing buckle in these cases, you will cheese wire the sclera, and probably I will go safely from inside and tackle the whole problem within inside.
Dr. Saleh, in such case like that, while the it's localized, superior-temporal retinal detachment, would like to consider some sort of pneumatic retinopexy in this case.
And I thought this, because the pictures were interrupted with me, I thought this is a total retinal detachment.
No, it is just as mentioned by Hamad. It's just only superior temporal. Is it, Hamad?
Yeah, but the problem, he was having 0.9 cupping with advanced glaucoma.
But
okay.
where is the break? Could you see breaks?
Yeah, it's in the superior temporal.
No, with this picture, even with advanced cupping, I will definitely go for pneumatic and cryo on the spot intraoperative, or later on. How old is the patient? How
He's
old?
34 when I patient.
Yeah, either to go intraoperative or post-op laser. But I will make sure that the injection to drain first, to sort of deflate the globe, so that I will go and soft globe and inject, and then do paracentesis. I don't know how is the situation of the anterior segment, but even if he's phakic, I will do anterior chamber paracentesis to make sure that the pressure will not shoot. And in fact, I will use also C3F8 0.3 cc bubble, so that it will expand, quadruple its size in the few days post-operatively. But
thank you.
I don't think the advanced glaucoma will change my routine for pneumatic, but I will make sure that the pressure will not increase.
Okay, thank you, Dr. Saleh. Could you proceed, Hamad?
We decided for this patient to go for vitrectomy. Unfortunately, the back for 25 gauge was not available that day, so we decided to go for 23 gauge vitrectomy. This is our surgical record, as you can see. In the beginning, we try to choose the area with least thinning for sclerotomies. We insert 4 sclerotomies, one of them in the inferior nasal part as a chandelier light. Then before we start the surgery, while we are entering our instrument, we found a difficulty before we started the surgery. We noticed the cannula came out from its place, and you can notice the superior temporal sclerotomy increase in size, and the inferior sclerotomies are fine till now. We readjusted the cannula, the nasal and temporal superior sclerotomy. Then we proceeded for our surgery. We started with a core vitrectomy with low infusion pressure because the patient has advanced cupping. Then we injected triamcinolone. Then we induce posterior vitreous detachment. Then we continue our surgery with the vitrectomy and chafing of the posterior hyaloid. While we are doing the posterior chafing of posterior hyaloid, the cannula keep coming out, and the size of the sclerotomy, the superior temporal one, increase in size. We readjusted the cannula in a place. If in the superior nasal one is increasing in size and coming out, we readjusted the cannula. We go in again, and you can see now we are doing diathermy for the retinal breaks. And after that, we injected perfluorocarbon to flatten the posterior bone and to shave the hyaloid anterior to the perfluorocarbon bubble. But suddenly we noticed deepening of the AC, and when we check, we noticed the superior nasal sclerotomy extended to the limbal side. We dissected the conjunctiva and we stopped the infusion. We dissected the conjunctiva to see the extension of this sclerotomy. Then we decided to close this sclerotomy to complete our surgery. We applied the 8-0 ficril to close this sclerotomy, and the infusion is off, and the eye filled with perfluorocarbon at this time. And we tighten the suture, and now we will open the infusion, and we will check the sclerotomy. Is it leaking or no? You can notice now we will open the infusion. It will open again, and keep your eyes also on the superior nasal, superior temporal sclerotomy. After that, we decided to put multiple suture of 8-0 ficril. And as you can see, there is a difficulty and cheese wiring and very thin with very elastic sclera. We put the second and third one. Then we applied the fourth long one over this sclerotomy. And you can notice here the difficulty. After that, we will tighten the suture and we will open the infusion again to check the security of this sclerotomy. Is it closed or no? Now we tighten this sclerotomy, the suture. We will open the infusion. After we open the infusion, we notice the sclerotomy is closed and secured. After that, we close the conjunctiva above this sclerotomy, and we proceeded to use the sclerotomy for the chandelier light in the inferior nasal one as a second sclerotomy size to complete our surgery. Our aim is to complete now the surgery. We went in again, we did air fluid exchange. Then we applied laser around the brakes and 90-degree around the brakes. And after that, we were in doubt either to choose silicone oil or long-acting gas tamponade. Keep in mind, we didn't want to risk the patient for another surgery. We decided to choose long-acting tamponade, but before that, we want to make sure that the superior sclerotomy are closed so the gas will not escape from the eye. We close the inferior superior temporal sclerotomy by 2-8-0 ficril. And also we will tighten the suture now, and to make sure that the gas will not escape from these superior sclerotomies, we will close the conjunctiva above this sclerotomy, and we applied fibrin glue above the nasal and temporal superior sclerotomies, and we observed for 5 minutes to check if there is leak or no. Then we injected the gas on the inferior nasal sclerotomy. Then we observed for 5 minutes more. After we observed for 5 minutes, we noticed there is a gap in the inferior nasal sclerotomy. That's why we apply fibrin glue above the inferior sclerotomies also. Then we observed for 5 minutes more to check the intraocular pressure and to check if there is a gap in the sclerotomy. Alhamdulillah, he was fine. And then we put the patient on a regular tablet of Diamox to prevent any spikes of high IOP that will lead to open this sclerotomy. This is his 2 months post-op. As you can see, the visual acuity improves to 20/50, even better than his baseline. And you can notice that he's having flat retina with still the gas bubble in the superior vitreous cavity. This is his OCT showing a pocket of submacular fluid, but he's doing fine. In summary, in dealing with patients with thin sclera, I divided them into 3 parts. In the pre-operative time, we have to discuss with the patient about the risk of this complication, and also anterior segment consultation for possible scleral batch should be considered. In the intraoperative time, we advise to use a small gauge vitrectomy like 25 or 27. Also, the infusion pressure should be low as much as possible, and we have to choose the best sclerotomy size in matter of less thinning, and we have to avoid the multiple entry and exit. And also, we recommend to use gentle scleral depression. And just similar to our case, it's better to avoid the silicone oil to not risk the patient to another surgery if it's possible. And also, fibrin glue and batch graft should be standby in OR. Also consider use 8O ficryl, and placing figure of 8 suture or ficryl mesh can be helpful in this patient. In the post-operative time, it's we recommend to avoid any spikes of IOP by putting the patient on regular medication of regular tablets of Diamox. Also, we recommend to observe carefully for leak and to avoid eye rubbing. And we have also to instruct even the nurses in the floor to be careful while giving the post-operative drugs. Thank you.
Yeah, thank you, Dr. Hamad, really, and Dr.
I have a
Abdullah
question
Al
for
Abdullah
Hamad.
for sharing us this case. And I would like to give you just only a 30 seconds, Prof. Saleh, because the time is now limited and we have 2 more.
No, thank you, Hamad. And my question to Hamad, why you didn't go for pneumatic retinopathy? I think this is quite classic.
Yeah,
even with we did it with also glaucoma, advanced glaucomatous patient.
Yeah, because the IOP was not controlled before the surgery. This is the first one. And the second thing, because the high IOP and with the advanced carotid point angle, we are afraid from inducing loss the optic disc in this arm.
Yeah, clear. Thank you, Dr. Haman. Thank you, Dr. Abdullah, for sharing this case with us. And I would like to move to the next speaker, Dr. Mustafa Maglia. Dr. Mustafa, could you share your screen?
Yes. طيب.
If we have time at the end, we can discuss more.
Assalamu alaikum, everybody. You hear me?
Yes, it's very clear.
Yes.
Okay, my presentation is about follow the retinal leads to reach the diagnosis. Yeah. 18 years old male came for a regular follow-up in retina clinic. He is known to have high myopia. His sister, who is 17 years old, developed neovascular glaucoma 1 month after cataract surgery. No history of hearing loss or spinal problems. No midfacial hypoplasia or high arched palate. Normal length of upper and lower extremities and digits. No history of joint hyperflexibility or scoliosis. No history of muscular diseases or skin lesions. So his best corrected visual acuity was 2200 in both eyes. Refraction, he was high myopic, -14 in both eyes. IOP with a normal, cornea was clear and normal diameters. Anterior chamber was deep and quiet in both eyes. Iris was normal. Pupil was round, regular, reactive, and lens was clear. So an examination of the right eye, it shows that the disc a little bit pale and a little bit tilted with parapapillary atrophy. Also, the course of the arcades is like going nasally, then temporally, which is aberrant course, and the superior arcades is looking stretched upwards. And also there is macular chorioretinal atrophy with also retinal thinning and choroidal vascular show, with also like a well-demarcated peripheral retinal thinning outside the posterior pole of the retina, with also some vitreoretinopathy. In the other eye also, it is showing that the high myopic features, the tilted disc, the aberrant course of the arcades, the spiral arcades is a little bit stretched upwards, and the chorioretinal atrophy, the choroidal vessels show, and also again the peripheral retinal thinning, which is well demarcated with some pigmentary changes as well. And on OCT, sorry, it's not the best OCT that we can that we get, but it is showing that the choroid is severely thinned, poor lamination of the retinal layers. Fovea looks a little bit rudimentary, and on the other eye, unfortunately, we couldn't get an ideal cut, but it is also showing that the choroid is very thin, and also both eyes, they have the reverse shadowing from severe thinning and also poor retinal lamination. On FFA, quickly, it also proves what we saw, that the spiral arcade is a little bit stretched upwards, and the aberrant course of the inferior arcades, and the retina is a little bit thin, but in the periphery there is well demarcated where we can see the choroidal vessels also. Here is the temporal to the macula, the chorioretinal atrophy, and the severe chorioretinal thinning as well. So here in the other eye as well, as we can see, almost the same changes with some pigmentary changes in the left eye as well. So my first question is, patient ophthalmic examination shows in the posterior segment the combined features of, what are the combined features that we saw here?
Well, Dr. Suleiman would like to make a comment in this case.
Yeah, so this is a very interesting case. The patient came for regular follow-up, and this is his fundus examination and fluorescein angiography findings. These are peculiar findings. His older sister had neovascular glaucoma in one eye, and then she developed retinal detachment. So this patient have been or has been following as high myopia and with no genetic diagnosis. You can see the features of high myopia, but there are additional features. The vessels are not normally oriented. There is the blood supply to the retina is not normal.
Okay. So as Dr. Suleiman said, the combined features of high myopia and abnormal retinal vascular development, actually, for the sake of the differential diagnosis of high myopia, if you want to go as high myopia, Stickler, Knobloch, Wagner, sorry, Lipral 1, LR PAP 1, and Pearse. Abnormal retinal vascularization, fever, incontinentia pigmenti, Adams-Oliver, fascio-capsulohumeral, muscular dystrophy, Norris disease, and again, Pearse. So what are the systemic evaluation and tests that can be requested for these patients? Anybody of the panelists can recommend for us?
Dr. Marwan, Professor Marwan, could you help? Dr. Suleiman, could you continue? Because I think
yes,
there is...
hello?
But we are late. Okay, Dr. Prof, go ahead, please.
I do have a problem with the connection. Anyways,
That's
So
okay.
in Pearson, they're usually not followed by us. Usually you find them in pediatric clinics suffering from nephropathy. So in such cases, you need to make sure that they don't have any kidney problems. So the first thing to do is request for renal function tests. And,
Okay.
yeah. In addition, probably I'm not aware. I didn't know if Dr. Mustafa mentioned the anterior segment findings, which are also peculiar for Pearson.
Could you mention
Which
it, please?
is the pinpoint pupil for that you usually find that is very difficult to dilate.
Okay, that's good.
Yes.
What's about 24?
Yeah. Okay.
hours?
We'll come to the anterior segment features. Okay. So the systemic evaluation can include the nephrological evaluation, urine analysis, 24 urine protein collection, renal function test, which is sometimes even can be normal with Pearson syndrome, but you will be surprised that on protein collection, they will have proteinuria even though the renal function test is normal. And neurological evaluation, will come to this. So genetic testing, we recommend that it includes LAM2 and LAM1 gene. The patient had proteinuria and on urine analysis and had LAM2 mutation. So the diagnosis was, as Dr. Suleiman and as Dr. Marwan said, it is Pearson syndrome. So brief quickly about Pearson syndrome. In 1963, Pearson and his colleagues reported two siblings with rapidly fatal congenital nephrologic disease, nephrotic syndrome in combination with extreme microchoria. As Dr. Marwan said, pupil diameter less than 2 millimeter. Zinker and his colleagues named the condition Pearson syndrome in 2004 when they reported two large families with the disorder. The pedigrees were consistent with autosomal recessive pattern of inheritance. Later, they found that it is located to LAM2 gene. So the association of congenital nephrotic syndrome and microchoria per se is enough to diagnose Pearson syndrome without the need of genetic testing. And there is a nice article in the American Journal of Ophthalmology which described the anterior segment features of Pearson syndrome, including microchoria, meiosis, posterior synechiae, iris hypoplasia, absence of dilator muscle, ectropion uvei, large corneas, corneal opacification, and cataract. But the problem is that posterior segment features were not well described. Well, the problem is that the microchoria offers a challenge for the retina specialist to get a nice examination and finding for Pearson syndrome, but it is also of paramount importance. Why? We have found that 100% of these patients have tessellated fundus. In article which is also co-authored by Dr. Suleiman, Dr. Marwan Abu Amma, Dr. Taysan, and others. They have parapapillary atrophy in 75%, punched out chorioretinal atrophy in 12.5%, and RRD in almost half of the patients. Why? Because the high myopia, on the other hand, there is also the peripheral ischemia, a vascular peripheral retina, as we saw in the patient, 87.5%, aberrant course of temporal arcades, 87.5%, straightened nasal retinal blood vessels, 75%, tortuous retinal blood vessels, 12.5%, and peripheral retinal pigmentary changes in 6.25%. And this is unpublished data, which is under the process of publication. So combined posterior segment features of high myopia and abnormal retinal vascular development commonly found in Pearson syndrome. Retinal findings can lead you to systemic evaluation, further suggest for you the systemic evaluation can guide you for which genes that you order and you get the diagnosis. And that's why I was inspired to take the title of my presentation. Is it sine qua non? It's not. These are the posterior segment findings in Poretible-Schauser syndrome due to LAMA1 gene mutation. Systemic findings of Poretible-Schauser include cerebellar dysplasia, cysts, developmental delay, high myopia, abnormal eye movement, and retinal dystrophy in this case, which is co-authored also by Lahmadi and his colleagues, which is also an unpublished case. And we see the same features that we discussed about. Thank you very much.
Thank you, Dr. Mustafa, for this nice case, and thank you for sharing this case as well. Thanking for Dr. Sulaiman to give us the chance to look for this case. Because of sake of time, I will proceed for Dr.
Just one comment.
Yes, go.
It's important to realize that not all patients have microcoria. So keep this in mind. The second point is that you need to check protein yourself. Not all patients come to you with a frank nephrotic syndrome and proteinuria. So this fundus finding or retinal findings led to the diagnosis of Pearse syndrome based on the recognition of the phenotype only.
I agree with you totally. It's peculiar. It is very well demonstrated by fundus photos here. So the ophthalmologists need to look for this really syndromes, helping as well the pediatric ophthalmologist to recognize these cases.
Yes.
Hassan, the terminology, once you see the retinal blood vessels or the temporal, for example, first go nasal and then curve, this is called situs inversus.
Yes, as mentioned by Dr.
Yes.
Okay.
Not mentioned.
Dr.
Yes.
Dr. Tariq, could you go to start because we have only 10 minutes remaining.
Assalamu alaikum. Thank you for the organizing committee, the panelists, and the audience for their attendance. So this is Tariq Al-Zaham, a first-year surgical retina fellow. My case is actually a short case, and I will try to present it quickly. So my patient is a 22-year-old male. He is medically free, a medical student. He presented to the retina clinic complaining of gradual decrease in his vision in the left eye for approximately 7 months. And he had a history of laser photocoagulation 6 months prior to his presentation by an ophthalmologist elsewhere. He's not complaining of any pain, and he was denying any history of trauma. On examination, his visual acuity in the right eye is 20/20, in the left eye is 2400. Now, otherwise, his intraocular pressures, anterior segment examinations were unremarkable. Now, upon examination of the fundus of the left eye, you can see a grayish depression at the temporal pole of the disc, and autofluorescence photo of the same eye showed a pale hypoautofluorescence temporal to the disc, which were suggestive of previous laser photocoagulation. Now, his OCT as presentation is, as you can see, is showing significant schisis involving three layers of the retina. You can most inner layer or the nerve fiber layer, and then the inner nuclear layer, and then the outer plexiform layer. He was also having an outer lamellar hole with only the eye limb covering the surface of the fovea. Now, as you have expected, the diagnosis is optic pit maculopathy with an impending macular hole of the left eye. Now, the question is directed to the panelists. What is the most appropriate management that you would offer the patient?
Dr. Muhammad, would like to make a comment about the questions?
Yes, it is obvious and very clear that the patient has already underwent laser, like barrage around the optic nerve. But we all know that the laser is not always mandatory in such patients. So doing vitrectomy and using a tamponade in most of cases can be helpful without even doing the 360 laser. So if the patient is aware about all the complications that including iatrogenic macular hole, I will probably proceed for perfluorocarbon with iron peeling, and may I consider iron inverted flap.
Prof. Marwan, I know that you published a lot about optic nerve head bit.
As Dr. Hazazi mentioned, laser will not work, full stop. Laser alone will not work. There is a recent meta-analysis about all the studies published regarding optic pit that was brought to my attention by Dr. Suleiman, published in 2019, and it compared pars-plana vitrectomy versus alone versus vitrectomy with iron peeling, or with gas, or with fenestration, temporal retinal fenestration, or with laser. And it showed there is no difference between all of them, which means that pars-plana vitrectomy alone would do the job.
Okay, Dr. Tariq.
Okay, so what we did actually, this is a short video of the case. We used 23 gauge vitrectomy using the Constellation system. As usual, we started with a core vitrectomy, and then we injected triamcinolone acetonide to stain the posterior hyaloid. And then PVD was induced using the vitreous cutter handpiece, and then it was propagated peripherally. And then the posterior vitreous was trimmed at that area. And then restaining with triamcinolone showed vitreous strands over the disc and in the temporal macula, which were removed successfully from over the disc. But in the temporal macula, it was very adherent. So we abandoned this technique just to avoid a macular hole. And then here we are attempting to aspirate the macular fluid through the cavitary optic disc lesion. And then we examined the Retina 360, which showed no breaks and no abnormality. And then finally, complete fluid air exchange was done. And C3F8 gas flush was done at 12%. Now, in the early post-operative period, 2 weeks post-op, the patient showed significant improvement of the retinal thickness. The schisis, especially the inner retinal schisis, is almost not there. However, the schisis in the middle retina and the outer retina are still there. And most importantly, we don't have any macular hole in the first post-operative visit. Now, the key points of this case, what we did as the panelists discussed, we did only vitrectomy with triamcinolone-assisted posterior hyaloid removal. We injected long-acting gas because we didn't do extensive peripheral vitrectomy, and the small gas bubble we chose the long-acting gas because we want a longer gas bubble, although we don't know that if gas is really helpful. At least we had a good post-operative, first post-operative visit outcome in terms of anatomy. His vision improved 1 line from 2400 to 2200. So that's pretty much the case.
Can I add, Dr. Hassan, that we should wait for at least a year before considering any other solution for the remnant intraretinal fluid or the skin cavities.
So to keep patient that to get your results. Thank you, Dr. Tariq, and I would like to thank you as well, Dr. Rabio, for allowing us to share this case. I would like direct questions to Professor Saleh. Would you like to do the same thing?
Yes, definitely. And what I think in this optic disc maculopathy is the main thing is the pars-plana vitrectomy. All the other adjunctive things are, I think they are secondary, and I don't think they sort of add to the success of surgery.
Dr. Suleiman, just for 30 seconds.
One quick comment that I would caution against ILM peel in this particular case, because you use macular hole if you do ILM peel. Unless you do fovea sparing ILM peel, then you may do it without problem.
Yeah, I would like to thank all of our attendees to be patient with us for this long, really webinar. Would like to thank the Saudi Ophthalmology Society for giving us this chance to participate in their really continuous medical educations through the Saudi Retina group. And I would like to thank all my colleagues from King Khalid Eye Specialist Hospital. I would like to thank my really speakers, Dr. Abdullah Al-Bihlal, Dr. Dua Al-Milibari, Dr. Faisal Al-Qahtani, Dr. Hamad Al-Subaya, Dr. Mustafa Magliya, and Dr. Tariq Al-Zahim for really very great and excellent presentations with really respecting the times. I would like to thank my respected panelist, Professor Saleh Al-Amru, Dr. Sulaiman Al-Sulaiman, Professor Marwan Abu Ammo, Dr. Muhammad Al-Hazzazi. Thank you really, and really appreciated your presence with us to late times. And really it was a great webinar, and really appreciated your efforts to do it. Thank you very much. Thank you very much for all.
Thank you, Dr. Hassan, for very nice moderation. And I also thank all the colleagues and my junior also colleagues for selecting very good cases.
Thank you very much.
Thank you.
Thank you.
مع السلامة.
مع السلامة.